time. So I will read through those 4 bios real quick here. So Dana Dahl is the Vice President of Membership Services and Rural Initiatives at the Missouri Hospital Association. Her role is to serve as the primary liaison between hospitals in the outstate areas and the association, offering chief executive officers resources, support, and education. Most recently, her role has expanded to include the responsibility of intentionally facilitating rural health initiatives for the Missouri Hospital Association. Her goal is to strategically support rural hospitals to enhance operations, intentionally influence policy development, and optimize high-quality delivery of care in Missouri's rural communities. Dana has been at the Missouri Hospital Association for 8 years. She holds a Master's of Business with a healthcare emphasis from William Woods University, is a certified professional in healthcare quality, and a fellow with the American College of Healthcare Executives. So welcome, Dana. Next, we have Toniann Richard, and she's the CEO of the Healthcare Collaborative of Rural Missouri. Toniann has raised over $12 million in grant funding since 2008, funds that continue to be directed towards programs that close access to barriers for the underserved. From 2018 to 2016, she grew her staff from 2 FTE to nearly 50 FTE, which is remarkable. Her career goals for the organization are to successfully develop a sustainable rural health network for providers, and is working with HCC's network to develop highly effective service delivery models for vulnerable populations. She believes firmly that organizations are more successful when they partner with others, something I also hold near and dear to my heart. Toniann has over 20 years of experience in not-for-profit and has many years of experience working with community networks. In the last 4 years, her expertise has been instrumental in successfully implementing and launching programs that improve access to care and healthcare delivery to our underserved populations. Then we will also hear from Dr. Laura Morris. She is a 2007 graduate of the University of Missouri School of Medicine. She is a Bryant Scholar who participated in the Rural Summer Community Program and Rural Track Clerkships during her training. She is originally from Holt Summit, Missouri, and most of her extended family live in the rural mid-Missouri area. She completed family medicine training in 2010 in Fulton, where she continues to practice just about 20 miles north of her hometown. Dr. Morris currently serves at the Division Medical Director of Family Medicine Obstetrics and is an Associate Program Director for the University of Missouri Family Medicine Residency Program. She moved into her role as Medical Director for the Rural Track at the University of Missouri School of Medicine in 2019. Dr. Morris is currently working to build new models of training students and family medicine residents in collaboration with rural health systems in Missouri. In 2019, Dr. Morris completed a timely American Academy of Family Physicians Vaccine Science Fellowship and is serving as the co-chair of the MU Healthcare COVID-19 Vaccine Committee, providing clinical leadership and public education on vaccination. And then we will conclude the bios with Lynelle Phillips. Lynelle received her BSN in 1989 and spent several rewarding years as a cardiac intensive care nurse. She received her Master's of Public Health from Emory University in 1992 with a specialty in environmental and occupational health. She went to work for the Centers for Disease Control and Prevention in several different capacities, including environmental health scientist of ATSDR, nurse consultant for the National Immunizations Program, and public health advisor for the Division of TB Elimination. She worked at the Missouri Department of Health and Senior Services as a nurse consultant and CDC field assignee for the tuberculosis program. She's also served as a consultant for the Heartland National TB Center. During the course of her career, she has numerous publications in the area of tuberculosis prevention and control, infectious diseases, immunizations, and environmental health. She served as faculty for the University of Missouri Sinclair School of Nursing and as faculty for the Field Placement Coordinator for MU Masters of Public Health program for over 10 years. Her teaching-related experience includes community health nursing, epidemiology, environmental health, and vaccine-preventable diseases. She has also led study abroad programs to Cape Coast, Ghana, and Cape Cape Town, South Africa. She currently has a dual appointment as an assistant teaching professor with the Department of Public Health in the School of Health Professions and has an extension nurse specialist with the MU Extension Service. And ladies, I will turn it over to you. Dana, I think we're kicking off with you. Dana, you're on mute if you're talking.
I'm so sorry. It's very difficult to unmute when you're screen sharing, apparently. Melissa, thank you so much. Yes, for that introduction. I'm really happy to be invited here. Rural health is a passion of mine. Like Dr. Morris and others, I grew up in a very small town here in California, in Missouri, and much of my family still resides there. So I've seen firsthand that impact of lack of access to quality care firsthand. So anytime I can help spread the word, I'm happy to do so. So I've been asked to talk to you today about MHA's role and how we've helped our hospitals battle COVID-19 in Missouri, specific to our rural hospitals. So just a few talking points here to provide some structure. I'm going to set the stage of what rural healthcare looked like pre-COVID, the impact of COVID on our rural hospitals, MHA's priority support areas, and some silver linings. So first, rural health pre-COVID. I want to set the stage here, and you'll just have to bear with me. I do have a lot of data that I want to share with you and statistics, but I really think it's important because the facts don't lie here. So as you probably know, the hospital landscape in rural Missouri looked dim before COVID. We have 61 hospitals in the state that we consider rural, which represent about 44% of our total hospitals. Between 2014 and 2020, there were 19 hospital closures in Missouri. Of those 19, 10 of those were rural hospitals. So you could see that map there on the left hand part of your screen. Those are the locations and the years of those hospitals. In addition to that, our data shows that 55 rural counties in the state have no hospital. That represents about 48% of our counties. So almost half of our counties do not have access to emergency care. Going on to financial. So financial instability has plagued rural hospitals for years. In 2019, approximately half of all our rural hospitals lost money. The average operating margin for this cohort was less than 0.5%. And part of that is just due to the rural poverty and the types of patients that our rural hospitals see. Poverty is a lot more prevalent in our rural areas than it is in urban. In fact, our rural areas see about 29% lower per capita income, and that's specifically higher in our rural areas for children and the elderly. And a lot of that is social determinants of health. These social determinants of health, those issues manifest in outcomes in the clinical environment, but it's really based on where our patients live and where they work, and where they learn and play, because oftentimes in rural communities, those environments are not healthy. Mental health is always an issue too when we talk about social determinants of health and rural health care. Our rural communities faced and will continue to face access issues because there's a shortage of psychiatric providers in our rural communities. And then unfortunately, on top of that, mental health treatment still carries a large stigma in those rural communities, particularly where it's small and remaining anonymous can be difficult. So some positive news. Despite the financial challenges, rural hospitals still remain economic engines for their small communities. Together, rural hospitals employ nearly 29,000 workers and have a payroll of over 1.8 billion with a B. We provide 518 million in uncompensated care. And as you can see, we have a total community benefit of 670 million. These numbers are big, and especially for our small rural communities. So then taking a look at the impact of COVID on rural hospitals. So as the pandemic made its way into Missouri, mostly our urban areas were impacted first. So our rural hospitals really began to prepare and brace themselves. They canceled elective procedures and outpatient services. They tightened their visitor restrictions. They began ordering PPE and other necessary supplies that they thought they would need. They quickly stood up their incident command centers and really put a good staffing plan in place. To be honest, they were preparing for the worst, hoping for the best. Support. So our rural citizens are known for their sense of community and that really hard work ethic. What we saw was COVID-19 was no different. Our rural hospitals quickly disregarded those market shares and those competitive lines and really stepped up to the plate for their urban peers and their other rural peers to help offer resources and manpower. So when COVID began seeing its way into rural communities, the urban areas were already at capacity. So what our rural hospitals did was provided a role to help with that surge. Rural hospitals kept patients that were COVID positive or otherwise needed inpatient care because they couldn't transfer them to tertiary care. And they also helped with something called reverse triage of patients. So they took patients from tertiary care hospitals that were no longer critical, but still needed some of that admission or inpatient monitoring. So this allowed the urban hospitals to take more critically ill COVID and non-COVID patients. So it really freed up the bed in their critical care units. Responding. So due to the increase of patient load and the spreading virus, rural hospitals faced workforce shortages. And this was really just across the board in general. This was by far the biggest concern or complaint that I heard from CEOs as I was making my rounds on those rural folks. And a big part of it was they really went into the pandemic with a skeleton staff to begin with. So when they had staff that were sick or were quarantined or recruited to other hospitals or traveling agencies, it really hit them hard. And that's, in addition to just simple burnout and people who just simply left the workforce. And then national supply chain shortages. I think we all know that as the nation and the world was responding, the supply chain quickly became an issue. Our rural hospitals felt that, particularly those that were independent and didn't have that system affiliation. So moving to MHA's priority support areas, as we were helping facilitate communication and response, we quickly noticed that our rural hospitals required a different type of support from us than our urban hospitals did. So our leadership team formed a quick rural health team of MHA staff who analyzed input that they had received both formally and informally from our members. And we developed these 6 areas of priorities for rural health: workforce, delivery and payment models, clinical care and community health, infrastructure, financial and operational, and coverage. So, of course, these priorities were all very present pre-COVID. However, they were definitely amplified because of the pandemic. So to best support our members in these 6 ways, we really amped up our communications. We increased our newsletters. We made sure information on our website was concise and timely and easy to find. We also switched our in-person education sessions that were scheduled to virtual and changed the topics to be more relevant and timely based on the COVID response. We held daily, weekly, and now really ad hoc regional and state meetings for our hospitals so that they could discuss the issues they were facing. We found it really beneficial to bring together like groups of individuals at hospitals. So for instance, the purchasing managers of hospitals from across Missouri. You could be in the most southern part of the Boot Hill or the most northern part, almost in Iowa, and probably seeing the same supply issues. So it was really helpful to bring those individuals together so they can network and learn from each other. One other thing that we did was held routine member calls for our member CEOs with the governor and his state officials. We did that beginning in March and all through 2020, and so far all through 2021, so that they have the opportunity to ask those specific questions, advocate for their needs, and just get firsthand information from the governor. So silver linings, although the pandemic has been tragic in so many ways, we're now beginning to hear and see some lessons learned that we hope will impact rural healthcare for years to come. One of those major developments has been telehealth. Obviously, telehealth has been around for several years. However, it's really been a low priority for our rural hospitals because they just lacked the resources and the money, and there was no real payment stream that was tied to this method of service. I also think there was a little bit of reluctancy from providers and patients that care would suffer if it wasn't in person. So what COVID has shown hospitals is that providers and patients can still have quality relationships, quality care, and in some cases, it reaches a patient population that we weren't able to see in person anyway, kind of going back to that example of seeking mental health treatment or care in a very small rural community. Another silver lining that I've heard from the CEOs is the provider and nursing staff's confidence and competence to treat higher acuity patients. So again, COVID pressed the limits of the bed capacity at tertiary hospitals. So rural hospitals treated and cared for patients that they normally would have triaged and transferred. So there's hope in that rural communities that more patients will get to stay local and have inpatient care locally instead of being transferred. From a workforce perspective, we've heard great stories about teams who have bonded due to the intensity and hours spent together. We've heard, it be compared to going to war together and just that bond that you build. There's also been a renewed focus on employee mental well-being. I talked to one CEO recently who had said, employee well-being has always been something that we've done. We've not done it well, and we've always wanted to expand it. But COVID quickly advanced the ways that the hospital could support the mental health of their employees. It really gave them the why and some of the how. I think everyone was just a little bit more willing to speak to it. And then finally, our rural communities now have a much better understanding of the importance of having a strong hospital in their service area. Many of our hospitals were strong leaders in their communities during the time of COVID. So they've really built those relationships with those community members. And we did recently poll our communities and found that confidence in hospitals is very high, which is good to see that the data supports what we were feeling subjectively. And then moving forward, our goal is to just continue to engage the necessary stakeholders and other partners so that we can continue to move the dial, build good strategic direction for our rural providers in order to have high quality and sustainable environments. And with that, Melissa, I'll turn it back over to you.
Thank you so much, Dana. I appreciate all that you all did during that time. Next, we're going to hear from Toniann and her experience from the Federally Qualified Health Center arena, but also from HCC and all the things that they have seen and done over the last 18 months.
Hi, everyone. I'm Toniann Richard. I appreciate the opportunity to speak to you today. I think if I could echo every single thing that Dana just said, it would be shy of applause. So definitely, I loved seeing, as much as we have hated the pandemic, I did love seeing rural communities really rise to the occasion. Relationships with hospitals that FQHCs had it within the history of the organizations. We saw a lot across the state of Missouri, hospitals and FQHCs and health departments coming together and breaking down some barriers. So I did not prepare slides today. I just didn't. So I thought it would be easier for me to talk about some of our experiences and the things that we've learned along the way, and then give people time to speak at the end and ask questions. So FQHCs in Missouri, especially in the rural areas, really had to take priority and make sure that the communities had access to testing and now vaccines. That was a real challenge. As Dana mentioned before, getting getting the supplies that we needed to do it, getting the PPE so our staff were safe as they were providing these testing environments was really critical. And I felt like, and our staff felt like that we were working every day just kind of with our hair on fire. I have a nurse practitioner that's on this session right now, and she talks about the daily huddles that we did via conference calls because things were changing every 3 to 4 hours. And our leadership team was at the end of the day having debriefs every day, and we would start at 6 o'clock at night, and it was a lot of times it was 10:30 or 11 o'clock just to debrief from one day and figure out what we needed to adjust for the next day. We were redefining busy. I tell people a lot of times, I know that we were busy before COVID. I know we were. I know there was fires we were putting out every day, things that needed to get done, but it seems like it's really hard to think about that right now because I can't think, it's hard for me to think about what those actual things were that we were doing. I also think that those of us in public health, there's a part of our soul that was really made for a pandemic. I have a nurse that she just said, as much as we hate being in this pandemic, these are the things that you learn in nursing school, and how to prepare your community. And the fact that we had staff and leaders in our community that were able to step up and say, we've got this. We're going to do the very best we can. We're going to adjust every day, and we're going to actually use some of those skills that we learned in nursing school, and we're going to be able to apply it to our community and then figure out how we move forward. So that also was really exciting to see. We developed, our leadership team also developed what we called a war room, where we just dumped, we kind of called it was kind of a parking lot. As things came up throughout the day that were exhausting for us, or just too much that we just couldn't come up with an answer right at the moment. We use a tool called Slack, and it became our war room. We dumped just thoughts in there or challenges. And then that is what drove our conversations at the end of the day and to prepare for the next day. Eventually, we got to where our leadership team was meeting 3 times a week instead of every night, and including the weekends. And so those tools really helped us digest those problems as well as come up with solutions for the next day. Our health departments were bare bones. I think that's very typical in a lot of rural communities in Missouri and quite frankly across the country. Health departments, while they really were built to respond to issues like COVID, over time their funding has been cut. They've had to reduce their staff, reduce their supplies, which made them really at a disadvantage going into COVID. There were things that they wanted to be able to do, but just did not have the capacity to do. Also, the funding that came out was not quickly appropriated and directed to the public health department so they could spring forward. At the time, we were also experiencing this workforce crisis around people that were willing to be on the front lines to do testing, to do education, to even come to work. And we knew that the hospitals really needed those frontline workers to be able to take care of people that were sick. And so health departments were quickly reaching out to community partners to help make sure that their communities had access to testing. I really applaud the health departments because they never gave up. They're continuing to fight today for more financial support. So in the future, health departments can be more prepared for this. I also think that people in our situations and your situations, rural communities are very resilient. We didn't see a lot of people give up on finding solutions. And so becoming okay, if you've ever heard me speak before, one of my big pieces that I always talk about is not to be afraid of failure, and getting our providers in a place that says, hey, we're going to try this and it may not work. Licensed providers, really, that's a scary place for them to be. Everything is very scientific. It's very evidence-based driven. And now we're getting into a space where that evidence isn't there. The history isn't there. And so our staff and the organizations that we work with, we really encourage them, hey, don't be afraid to fail, because that's the only way we're going to figure this out. Because what we do today might work today, but it's not going to work tomorrow. Also getting our board comfortable with that piece of failure and being able to kind of dust ourselves off, get up the next day and try again. And then I think what I'll end with is also this idea of what we had to do as leaders of organizations. And so it was really hard for me as a leader to continue to see my staff out there working hard every day on the front lines, knowing that was a piece that I couldn't do. I couldn't do a nasal swab. I couldn't. I directed traffic. I got the worst sunburn of my life ever on a day because I didn't wear sunscreen, which was really not smart. But things that I saw them, their exhaustion, I couldn't do. I had to redirect my efforts into finding things that I could do that would be best to support them. And so what that meant was working on the legislative campaigns to get telehealth services reimbursed on both sides of the aisle, working on funding advocacy so we could continue the work that we were doing. Make sure that I was in contact every single day with PPE vendors. I mean, we were borrowing and stealing to get things to our first responders, to our police force, to our ambulance guys. All of that stuff, thinking about that global picture, was ways that leaders really had to step out there and say, we're gonna kind of ride or die with this, but we're gonna have to be there for you. And so I think it made our providers also realize that our leadership teams don't sit in these ivory towers and just sit at their computer all day. That this pandemic put us in a place where we said, hey, this is our opportunity to shine as well. In closing, I'll just say that probably my proudest moment for our organization with COVID is that during the pandemic, we did not lay off a single person. We did not eliminate any jobs. In fact, we grew jobs. The dollars that were invested into community health centers, we put into capital improvement and sustainable positions within the organization. So it's not a one-time drop for us. And it will set us up to continue to serve our communities in the future. And that was a priority for our board and myself going into this, was that we knew that we had to maintain jobs. Most of the people that work for us are the breadwinners of their family. They carry their health insurance, their benefit package. We made that commitment to our staff on day one, not knowing what would happen in the future, and we were able to maintain that. And so that's my proudest accomplishment. And Melissa, I will turn it back to you.
Thank you, Toniann. I appreciate everything that you all have done. Dr. Morris, would you like to talk about COVID-19 from your perspective?
Thank you. Yes, and I have really enjoyed so far hearing from Dana and from Toniann, and every couple minutes as they were speaking, I get my pen out and I was jotting down some notes because it just echoes so much the experience that I think we've all shared with COVID-19 and its impact. And I'll speak to you a little bit more from my perspective as a clinical care provider in one of those communities. I work at Callaway Physicians in Fulton. In fact, I am speaking to you from the conference room / telehealth space / lecture auditorium / breast pump room in the basement of my clinic, because it's a multi-purpose area, and we have found all sorts of new uses for spaces that we didn't need before the pandemic. So I've worked here in this community for my entire clinical life, and I was a resident in family medicine at the University of Missouri. And one of the reasons I chose to stay at this program is because it offered the opportunity for clinical training in a rural community. And as mentioned in my bio, I am a Callawesian, which is the technical term for someone who lives in Callaway County. And you know that if you're from Callaway County. So I practiced pretty close to my hometown, and I did a lot of clinical work here, both pre-medical and during medical school. So I feel really connected to this community. And resilience was a word that I think that Toniann just emphasized, and that really, I think, speaks a lot about the community and what I saw here. So I want to speak about it from the response of patients. So first off, this pandemic has been going on long enough that I think for a lot of us, it feels like it's been through several life cycles, right? It was is this pandemic actually going to affect us in rural America or in rural Missouri? And that was kind of the first, maybe we were optimistic, in the beginning, and that January, February, March, is this actually going to impact rural communities? Because it feels like it's just in New York, or it feels like, okay, now it's in St. Louis, or maybe it's going to stay in Columbia, and it's really not going to get here. So there was a little bit of denial, I think, both, or maybe just we didn't know what to expect. Denial sounds harsh, but there was the delay and the impact and the arrival of COVID in the rural communities. And I think that gave us a little bit of a false hope potentially in the beginning that this was not going to be as impactful in rural communities. And so we heard from Dana about how rural hospitals in the beginning, they were sending PPE to larger communities and sending that to urban hospitals that needed supplies. And so there was this impression that maybe the rural areas could be spared. And then when COVID actually did arrive, so I remember late last summer thinking that I looked at all the messages that were in my electronic health record in my inbox. And out of 14 messages that accumulated during the course of a half day of clinic for me, 10 out of the 14 were related to patients that had COVID. And it was, they needed testing for COVID. They've been exposed to COVID. Their significant other had COVID. They were home from work and they thought they had COVID. Do they need to go to the hospital because they know they have COVID and they have shortness of breath? And so it was just this constant barrage of clinical work related to COVID, even when I'm primarily based here in an outpatient clinic. And so our patients felt that. And then the anxiety set in for patients related to COVID. And so all of the things that we now find to be so commonplace, the masking, the difference in how you go pick up food, the way that you come to the doctor's office. For a while, we had patients pull up outside and call the front desk to let us know that they had arrived. And then they waited in their car until it was time to come in. And then they came in one at a time. There are no visitors in the clinic. And so we just drastically and rapidly changed all of these workflows and processes, and it impacted us as employees and as workers and caregivers, but it also really impacted our patients, and it changed that experience of receiving healthcare and of feeling comfortable accessing healthcare. What's it like to go through an entire course of prenatal care without your partner at your side in the clinic room to hear that baby's heartbeat or to see the ultrasound with you? What is it like to get a diagnosis in a clinic room after a CT scan and to have your daughter on the phone, on speakerphone next to you on the counter instead of in the chair next to you? So we really felt all those, and that perhaps is more universal than in rural clinics necessarily, but it just goes to speak to how quickly and deeply this changed our healthcare delivery mechanisms in clinics and hospitals. But in my clinic, it was just so drastic and so real and so quick. You know, I still see patients on telehealth, and I'm grateful for those changes and that adoption. And I think that's one of the measures of resilience and the pieces out of this pandemic that will stick with us and perhaps positively impact healthcare moving forward. But today, out of 12 patients in the morning session, I saw 3 were on telehealth. And we're sort of feeling like we're coming out of the woods here for COVID-19. So this is a lasting impact on the way that healthcare is delivered in our rural communities that I hope will actually represent a positive impact for that access to care. I was in the breakout session earlier on community engagement, and one of the points brought up was about broadband access and how connected Missouri is or is not. And I will tell you that nothing has been more consistent in my experience of being a healthcare provider during a pandemic than the fact that I sometimes cannot connect to patients. I cannot get a hold of them on Zoom. You know, we're trying to modify these healthcare delivery methods, and we're trying to continue to provide preventive care and even, I mentioned prenatal care, and we need the internet. And who would have thought that the thing that came out of a infectious disease that ravaged our globe is the fact that we need internet, right? It's not just for Netflix anymore. It's actually important to provision of healthcare and to disease outcomes. And so I know that seems like it might have been obvious, but here we have Cal Fiber in part of Callaway County, but in parts of the county that are not as connected, those patients were still seeing a barrier to access care. So we've thrown all of these COVID barriers in the way. And now the virtual, solutions to some of those concerns are still unavailable to some of our patients in rural areas, more so than those that are in urban areas. I want to kind of pivot at the end here to mention hope. And I think that that's where I want to land, is that I have felt and seen that resilience. I have felt the grateful, thanks of patients who are just so happy that our clinic systems, that our rural hospitals have been there to provide that backbone of care and that steadfastness for them through the pandemic. And I feel hopeful as we move forward with lower case numbers and fewer hospitalizations. We can breathe a little bit as the pandemic hopefully winds down. And also, as mentioned in my bio, part of my role with MU Healthcare in the last 6 months or so has been our push for vaccination. And so we have really felt that that's the key now moving forward, and how COVID will hopefully make its lasting mark in our rural communities is that we can successfully push out truthful vaccine information and access to vaccination for our rural patients and bring them on par. That shouldn't be something that living in a rural county in Missouri means that you're behind on your access to vaccine and the way to end this pandemic safely and hopefully for all of us. So I'm doing my part every day. I challenge everyone on this call to do your part with that as well. And I look forward to answering any questions that you guys have for us. I'll turn it back to Melissa and Lynelle.
All right, thank you so much, Dr. Morris. I appreciate your perspective. Lynelle, did you want to share your perspective? And you had slides, correct?
Yeah. Should I share them from this end or?
You can. Yep. If you feel comfortable.
Okay,
If not,
I will do that. And
okay.
I will also attempt to convey my humility or my sense of humbleness in following these 3 speakers, in that, boy, what a year you guys have had. And so I'm really touched by what you had to say today. So I'm going to talk a little bit about maybe moving forward, like where we've been and where we're going. And I didn't really prepare slides today either. I had students do it. So, and I'll explain that in a moment. But one student wrote to me in my vaccine preventable disease class that she noted that Phelps County had 134 COVID deaths, and Boone County only had 84. And her thought was, how is this possible? And is this something that is echoing across our state in terms of rural versus urban COVID experiences? And so that was a good question. So I have another young student, a sophomore in my undergrad epidemiology class, and he was interested in a project. So I showed him where the data are to explore this, and we learned about incident rates and things. So he put these slides together. His name is Calvin Winkler, and I think you'll see he did a really good job, and gives me hope for the future of these kids. So so the county population data we used was from the Census Bureau, and we looked at the dashboards. You guys are all familiar with the dashboards. And then we looked at how to define rural versus urban. And we used the Department of Health and Senior Services definition. So Columbia would actually count as urban, and Jeff City. And then you see the rural, kind of 99 rural counties. And so this is what we found, and this is really crude first run analysis. I checked around. I don't think anybody has done this math yet, but it was a little surprising to me in that rural areas are not as densely populated, so you would expect less transmission of an infectious disease. But this is a very, very modest difference between rural and urban areas, but statistically significant. So we found that rural counties were 10% more likely to be infected with COVID. Let me see if I'm reading this properly. To more likely to die of COVID than residents of urban counties. And then residents of rural counties were about 4% more likely to test positive. And that's looking at PCR and PCR plus antigen tests. So, I think this echoes sort of in a quantitative way what you all talked about in a more experiential way, that our rural counties really suffered, and this is tragic to see these data. And then at the same time, we're looking at, as Laura pointed out, our path moving forward, which is vaccination. And so how are we doing overall as a state? We're doing really good. We're at about a third of our population has at least initiated vaccination. And but these are the counties that are lagging behind. And guess what? There are rural counties. So it's a little hard to tell from the map coloring that the state uses, but I enumerated on the side here some of the counties that are still lagging behind and getting vaccinated. So what's going on with vaccine hesitancy in rural Missouri? So those counties that I pointed out, they're predominantly white, predominantly a lot of folks living in poverty, underinsured, uninsured. You guys know the whole picture of what's out there. And then there's this political bit that's emerged in polling data. And so that's an issue. So we're interested in this in Missouri and what we can do to learn more about what some of the hesitancy issues are. So we're working with the Extension Office folks who are out there as field staff in our rural areas. And these are some of the comments that they're hearing from their communities as to what some of the source of the hesitancy is. And you can read those, trying to understand herd immunity, try to understand clinical trials. I don't know what to make of the third bullet. And so, but we need to learn to be able to respond to those. So this is, I think, moving forward, a bit of a paradox that the Missourians most at risk for COVID disease and death are also the least likely to be vaccinated. And so that's a challenging public health problem moving forward. We've learned a lot about trusted messengers, and that rural folks do, getting messages out relies on trusted people in their community. And so we realized that our extension service folks are immersed in the rural communities and are trusted members of their community and may be helpful in this effort. So the Centers for Disease Control is partnering with some of our extension service folks and developing and operationalizing some of our strategic communication strategies. So I know Laura Morris has some great skills in vaccine safety communication, and we need to get that subject matter expertise out to our rural areas to help move the needle more in vaccine acceptance. So here's some of the partnerships going on with the Missouri Immunization Coalition and the School of Journalism, and the Missouri Foundation for Health has done some Stratcom research. So hopeful moving forward, but also acknowledging there's a lot of challenge and a lot of frustration and distrust that emerged from all of the COVID activities that we've had to have in the last year. And I'm going to wind up a little early so that we have time for questions. I do want to mention that the Missouri State Immunization Coalition Conference is coming up in June. So there's your save the date. I hope you can make it. It'll be a virtual conference.
Thank you,